Okay, welcome everybody. Take your seats. We're going to get started soon. I'm so proud to say that this is our first event, inshallah, the first of many. So welcome to the Salaam Centre Medical Community event. Bismillah ar-Rahman ar-Rahim. The idea with this isn't necessarily to be giving medical talks, because alhamdulillah we have so many medical talks out there, but it's really just an idea for us to get to know each other, for us to learn from each other, and really to benefit from each other's expertise, to network. I've known my brother Muhammad for many years, but I can honestly say that other than knowing that you're a consultant in Luton in A&E, I actually don't know very much about where you trained or your medical school or what you do day to day. So I'm actually really looking forward to hearing from Muhammad today. So before I introduce Muhammad, I thought I'll just introduce the forum here. So we're sitting somewhere pretty special. It might not be particularly special in terms of a porter cabin, but actually this is the site of where we will be, inshallah, organizing for and coming together as the Salaam Centre. And one of the reasons why we were very keen to have our first event here is because we've got the site next door, and we were hoping for amazing weather and for us to be able to look out onto the foundations that are rising up. And we might feel it's safe to go and venture out later on, or we might think it's probably best just to stay inside and have coffee and croissants. But really what we wanted to do today was just an event where we come together, network, socialize. God knows that when we were kept apart for 3 years because of COVID, actually we really missed just being able to come together. So thank you so much for joining us today. The idea here is to form a medical community, but medical not because we're all doctors, but very much medical because we're either medical in terms of being doctors or allied health professionals. And I'm so happy to see people who aren't even in the medical profession here, but people who are, members of society or patients who are interested in this topic. And it really doesn't get much bigger than this. So when we discussed what our first event should be, well, we thought actually, well, the NHS is going through tough times. This would be a very good idea for us to discuss the difficulties within the NHS, and who better than someone working in emergency medicine. But actually, as the event has got closer and closer, if anything, the crisis has got bigger and bigger. And actually, when I started in the NHS some 15 years ago, I would never have thought that we'd get to the position we are in now, where it is just crisis and we have ambulances waiting outside A&Es, and people are having to carry their own family members into accident and emergency departments because they know if they call 999, they will end up waiting 2 hours for an ambulance with all the risks of doing that. So I'm very proud to say that our speaker today is Muhammad Asaria. He's a consultant in emergency medicine in Luton and Dunstable. He's going to be giving us a talk, but the talk is going to be short because we really want to open it up to discussion afterwards, to see actually what we can, our own experience of the NHS and how we can sort of, I guess in some ways, work through the maze of the difficulties that the NHS is going through at the moment. So welcome to you, Muhammad. Thank you so much for accepting our invitation to speak today.
Thank you very much, and thank you very much, Zaid, for organising the event as well and going through all the effort and doing everything. Very much appreciated. It is an honour to be here and speak in the first ever event of the Salaam Centre Medical Community. So thank you for giving me this opportunity. What I'm going to talk about today is I'm going to talk about the crisis in emergency medicine. I work as an A&E consultant and a consultant in emergency medicine. So I'm going to focus mainly on emergency medicine. The whole NHS, as we know, is in crisis. And we have people here from a wide wealth of specialties, and it'd be very interesting to hear from all of you about what you're going through on a day-to-day basis. So I'll try and speak for maybe 20 to 30 minutes on the crisis specifically about emergency medicine, because that's what I know. And then hopefully we'll have some fruitful discussion afterwards. So first, I thought I'd start with a few cases. Okay, just some case scenarios. These cases are taken from tabloids such as The Sun, The Mail, because they love giving us cases of things that are not quite right. And working in emergency medicine, you read some of these and actually you can imagine them happening. They don't actually sound far off from the truth. So This is a chap called Muhammad Ehsan. He went, a 45-year-old gentleman who went to his GP complaining of abdominal pain. His GP was concerned that he may have perforated and therefore sent him into A&E to be seen. Muhammad Ehsan was made to wait on a plastic chair in A&E with his abdominal pain. There were no beds, no trolleys available in the emergency medicine. The hospital, his local hospital, was completely full. He waited, he was seen, he had all his investigations, all his scans, but he spent 36 hours sitting on a plastic chair in the emergency department. Now, if I was fit, well, healthy, I would struggle to sit 36 hours on a plastic chair in an emergency department. This is somebody complaining of abdominal pain. He had some painkillers, he had some anti-sickness medication, and fortunately, he was found not to have anything serious wrong with him and was able to be discharged, but he spent 36 hours sitting on a plastic chair in an emergency department. Next, Keith Royals, another case that's been in the tabloids. He's an 85-year-old gentleman who suffers with cancer, on chemotherapy. He was taking a walk in his garden and he had a fall on the patio. It was raining. His daughter called an ambulance. Keith Royals spent 8 hours waiting for an ambulance to come whilst he lied down on the floor in the rain. 8 hours for an ambulance to come. He then was taken to hospital, found to have a neck of femur fracture, which was fixed, and he was then safely discharged. So those are just two cases I wanted to highlight, and honestly, it's things that we see every day. They are not far from the truth at all. This is just a picture I've taken from Google of a waiting room in an emergency department, showing how packed it is. These are all patients who have come in, who some of them may be COVID positive, some of them may have flu, some of them may have all other kind of conditions, all sitting together. And I'll be honest with you, this actually looks much more civilized than what a real A&E waiting room can look like. There's nobody lying on the floor. People are most people have a chair. This is another picture I found on Google that just shows that some people are standing, and that can be on hours on end because there's just no space for them to sit down. Another picture taken off a trust of loads of ambulances waiting outside an emergency department. Each one of these ambulances will probably have a patient inside with 2 paramedics, all waiting to offload their patients in the emergency department, but they just can't because there is no space for the patient to go. So these ambulances are stuck, waiting there. They can't go to their next patient who needs them, and yeah, they're rendered useless because they're just waiting outside an emergency department just to drop off a patient. But there's no space in the hospital for that patient to go to. So, I apologize in advance if this is very statistics heavy, because I'm going to show you a lot of graphs that demonstrate the problem in the emergency department, what has gone wrong, and the reasons behind it. So, firstly, it's easy to say that it's because the ED attendances have gone up, because the emergency department attendances have gone up, that's why we're in this crisis. But actually, if you look at it, this is a graph that shows the attendances between 2012 and 2022 to the present situation. The attendances have not actually gone up that much. They've been gradually increasing, and you can see that massive dip during COVID when everyone realized it's safer to stay at home with their condition than actually go to the hospital. But we've had bouncing now back to normal levels, but the attendances haven't actually increased massively to have resulted in the situation that we're in today. This is a graph that basically shows how long every single patient spends in the emergency department. So the line at the top is the one that shows the patients who need an admission into the hospital from the A&E department. And you can see that that's where we really have our problem. You can see in the last year or so, in the last 12 months, there's been a massive increase in the length of stay of the patients in the emergency department waiting to be transferred into the ward. And you can see that the medium length of stay now is almost 400 minutes. So that is what, 6.5 hours-ish. That's how long patients are, on average, waiting in the emergency department. Gone are the days when we had the 4-hour target, which you can see is the dotted line on the graph, is where that was a target in the past, but we're nowhere near meeting that at all in the present state. So the problem is patients are waiting way too long in the emergency department. These patients are occupying trolleys, and then the new patients coming in just have no space to go. This is basically showing the number of patients waiting for 12 hours or more in the department from the time they arrive to the time they leave. And that could be going home, or that could be going to a ward. And you can see that in 2022, all of a sudden, there's been more than double the number of patients waiting in the emergency department for 12 hours. This is taken from the Royal College of Emergency Medicine. The data showed to us by the government normally is 12 hours from the decision to admit a patient. Problem with that data is it doesn't account for the fact that the patient's been waiting for 12 hours already before that decision to admit takes place. But the Royal College of Emergency Medicine have gathered this data. So this is the number of patients waiting for 12 hours from the time they arrive to the emergency department to the time they leave it. And you can see that number has doubled in the last year. Okay, so then this graph basically shows how long it takes for a patient who comes via ambulance to be offloaded into the emergency department. And you can see the line at the top that shows the current data from 2022, 2023. The percentage of ambulances delayed by more than 30 minutes to be offloaded into the emergency department is higher than it's ever been. And you can see that at the moment, 1 in 10 ambulances are waiting longer than 12 hours. Sorry, this is longer than 1 hour to be offloaded, just for them to be offloaded from the ambulance into the emergency department. Now, this doesn't show the whole picture because there are ambulances waiting 7, 8, 9 hours in the country, sometimes even longer, just to be offloaded. But this just shows that the number waiting for longer than an hour is now 1 in 5 ambulances waiting longer than an hour. So, again, is this because we've had more ambulances coming? Actually, the number, if you look at the 2022-2023 line, the number of ambulances arriving to the emergency department is lower than it's ever been before. That may partly be because of the fact there just aren't the number of ambulances because they're all waiting to offload their patients, and that's why they can't get to the next patient who needs them and bring them into the emergency department. But the number of ambulances arriving are lower than they've ever been before. And actually, patients spending long in the emergency department, spending long to be offloaded from ambulances not being able to get to patients in time, it's estimated that this is contributing to 500 excess deaths every week. So 500 people a week are dying as a result of these delays. So I'm just concentrating more on the ambulance delays for a bit. So this obviously affects the ambulance's ability to go to the next patient, collect them, pick them up. So if we look at the category 1 ambulance response time, so by category 1, these are the patients who are in cardiac or respiratory arrest, patients who are not breathing or have lost their heart rate, their heart's no longer beating. And the mean target that the ambulance services aim to achieve is they aim to get to every one of these within 7 minutes. However, recently that has got closer to 10 minutes. And if we look at the top blue line, which is the 90th centile, they're actually taking roughly 20 minutes to get to some of these patients. If a patient is in cardiac arrest and the ambulance hasn't got to them in 20 minutes, that patient is dead. There's nothing more you can do for them. If we look at category 2 ambulance response times, it's even more concerning. So category 2 are all your patients who are still breathing, who still have a heart rate, but are complaining of chest pain, who might be septic, who may have had a stroke. All these patients, you can see the response time. Again, the target for these patients is around is 20 minutes, but the mean time is now closer to an hour. And if we look at the 90th centile, you're looking at 2 hours, 20 minutes. There are some of these waiting for even longer than that. So if a patient has had a stroke, they need to be thrombolyzed, have the treatment within 4 hours. If they're waiting just 2.5 hours for an ambulance to get to them, they're not going to get that treatment in time. It's just not going to happen. Or a patient with chest pain who's having a ST elevation MI needs to get their PCI within a certain time. That's just being delayed because we cannot get to these patients in time. And category 3 ambulance response times are elderly patients who have fallen, who can't get up, patients who are in pain and need response. They're all deemed category 3 ambulance, category 3. And if you're looking at the 90th centile for that, you're looking at between 8 and 9 hours now. there are cases of patients waiting over 24 hours for an ambulance to get to them. How does that affect them clinically? So a patient is elderly patients fallen on the floor, spending 24 hours on the floor before an ambulance gets to them. If they had a simple cut to their head that just needed closing and being sent back, that's not going to be the case anymore. If they spent 24 hours on the floor, they'll have pressure sores, they'll have their muscles will have wasted, they'll be in rhabdomyolysis, all sorts of extra problems. So these patients who just need a small wound looking at now are completely medicalized and are going to be spending weeks in hospital. Okay, so just summarizing most of the problems we're having in the emergency department. The main one is overcrowding. We have no space. There is nowhere, because all the trolleys are completely filled with patients who cannot get into the ward, there is nowhere to see the new patients who are coming in. Patients are waiting in ambulances and actually being seen by us in the back of ambulances now because they can't get into the emergency department. We're seeing patients in corridors, so there's just no patient confidentiality because they're seeing somebody while somebody else is right next to them. We're unable to deal with mental health patients. There are patients in mental health crisis having manic episodes, waiting for mental health beds, who are waiting for days in the A&E department. And these patients generally take one-on-one, so they need a nurse looking after just them, or sometimes even more than one nurse just looking after them to make sure they're okay. Long ambulance offload delays we've already mentioned, the long ambulance response times. And another problem is the fact that patients are spending up to 24 hours, sometimes more, in the emergency department means the staff in the emergency department, there is no extra staff, there is no extra space, but they're not only managing the emergencies coming in the front door, they're also working as a ward, making sure that the patients have had their second, third, fourth doses of antibiotics, have had their regular medication. So the same number of staff are pretty much doing the work of 2, 3, if not 4 individuals. So, why are we where we are? What has caused this problem? Okay, so one of the main reasons we've got this problem is the length of stay that so we don't have an increase in the number of patients coming into hospitals, but the amount of time each patient spending in hospital has gone up. Could be down to an aging population, could be down to the fact that patients now have multiple things wrong with them. It's not simple. But if we look at the of the amount of time that patients if we look at the number of patients spending more than 7 days in hospital, you look at the line at the top, the dark blue line showing 2022, 2023, it's higher than it's ever been before. And if we look at the data for patients staying longer than 21 days in hospital, again, the 2022-2023 data is higher than it's ever been before. Okay, so I've given some potential reasons as to why this could be, but one of the main reasons, in my opinion, as to why this is the complete breakdown in the social care system in this country. And therefore, there are patients who are able to be discharged, but we just cannot get them home from the hospital. They're just stuck because we cannot get their social care in place. And I can speak about one of my elderly family members who had a fall at home, broke a few bones, was seen by an orthopedic surgeon within 24 hours and decided everything was to be managed conservatively, but ended up spending 2 weeks in hospital because we couldn't get the social care in place. In those 2 weeks, the individual had a hospital-acquired infection, the individual was severely constipated, went into urinary retention, had an acute kidney injury. So patients who have simple injuries are then being medicalized and having medical problems as a result of their increased length of stay in hospital. And it gets even harder than to send them home. So this graph basically shows that if they're in a hospital, there are 100 patients who can be discharged. The hospitals are generally only managing to send 50% of them home. The other 50% are staying in hospital. And that situation is getting worse. Okay, so I mentioned social care. If we look at the funding that the government has the series of governments have put in social care since 2010, and the bars basically show a real-term change compared to 2010, 2011. So only in the last couple of years have we had a slight increase in the real-term change compared to 2010 and 2011. But if we take this per adult patient in the country, we are now spending £10 less per adult in the country to what we were spending in 2010, 2011. So although the amount of money has gone up because we've got a larger adult population, actually if we do it per patient, the funding has actually decreased in real terms. In cash terms, it's increased a lot, but once you take inflation into account, the actual amount per patient has decreased in the last 10 years, not increased. Okay, need to mention staffing, because again, that's one of the problems. Staff numbers, obviously short-staffed, but the fact that we're getting each staff member to do the job of 2, 3, 4 people is not sustainable. So they'll do that for the first few months, but staff morale is at all-time low. The number of nurses leaving the profession is at all-time high. The nursing turnover is much, much higher than it normally is, meaning we have to train new nurses up to do the same job, all taking time, and staff sickness is at an all-time high as well because morale is so low. All making the situation, a bad situation, even worse. And if we look at the number of nurses in the UK, you can see that between 2020 and 2021, there has been a massive fall in the number of nurses in the UK. Could be down to Brexit, could be down to burnout, it could be down to COVID and people said we've just had enough, we don't want to carry on in this profession, but the number of nurses in the UK has massively fallen in the last year or so. If we look at NHS spending, you can't talk about the crisis without looking at the spending that the government is putting in the NHS as a whole. This graph shows the NHS spending since 1980 to now. And if you actually look at the red line at the bottom, and you look at the last 10 years, which the red line at the bottom adjusts for changes in population size and demographic structure, actually, we haven't actually put any, in the last 10 years, we haven't increased our spending per person at all in the NHS. So the amount of money we're putting in the NHS has stalled in the last 10 years if you look at it per person. Okay, overall, obviously, it's increasing year on year, but the fact it's not really keeping up with the increase in our population size. So, potential solutions. Some of these are also, the solutions are not my solutions, so these are solutions that have been put forward, and I will talk about the pros and cons of most of these. Okay, so, firstly, we need to try and stop people coming to the emergency department. So we have the NHS 111 system, which you call, and is, I know we've got Vaz here who's heavily involved with NHS 111. He can tell us a little bit more about it, but idea is you call them and you'll see, someone from the health professional will tell you whether you need to go to A&E or where to seek help. So that idea is we stop people coming into the emergency department. You can have more walk-in centres. You can try and fix a primary care situation in the country, and we've got loads of people from who are as GPs here, and it'd be very interesting to hear from them about what the situation is in primary care at the moment as well, because as we know, the whole NHS as a whole is in crisis at the moment. It's not just the emergency department that's suffering. Then ambulance services have put forward some sort of solutions to fix their problem. So you've got what's known as intelligence conveying, where an ambulance service will go to a patient and then they'll find out which hospital has the shortest wait time for ambulance offload, and rather than taking you to your local hospital, even if it means driving an hour extra, if one hospital has a 2-hour offload time and the other has an 8-hour offload time, they'll drive to the one with the 2-hour offload time so that they can offload that patient quicker and get to the next patient. Problems with that is patients end up going to hospitals which are one, further away from them. So if you have an elderly patient who needs family members going, they have to travel a lot more. And two, that hospital probably doesn't have any information about that patient at all. So if you've got an elderly patient with multiple comorbidities, that hospital will have none of their records with them, and it leads to an increased length of stay in hospital. Handover spaces is something that's been put forward. So we build tents in the fronts of hospitals where the ambulances can put patients in the tents and then go to their next patient. Problem with that is then you have tents with undifferentiated patients, haven't really been seen by a doctor, don't know what's wrong with these patients, being looked after by minimal staffing. So it's something that the Royal College of Emergency Medicine is pushing against quite heavily. Would it be better to put patients who are ready to be discharged into these tents, who we know what's wrong with them, who are medically fit, just waiting for a social care package? I don't know. But those are solutions that have been put forward. And then there's this drop and go where I think in what I was hearing is in London, some ambulances have threatened to say that if they're waiting longer than 45 minutes, they're just going to drop the patient off and go. I don't personally see how that's going to work, because if there's no trolley space to put that patient, are they just going to drop the patient on the floor and go? I don't know. But that's what they've threatened, so I don't know how that's going to work. But that's what they've been talking about. Okay, and then there's some local solutions that individual trusts can do. Can have more efficient discharges. So if you need to put more pharmacies to get the TTOs done faster, you can put that in place. You can have discharge lounges, which we discussed, virtual wards. So patients come into hospital being admitted just because they're waiting for a scan. So they spend a night in hospital just so that they can have the scan the next day, or just because they need a cardiology review the next day. Can they go home and be brought back the next day for the scan, for the cardiology review? I know some trusts are very inefficient in that as soon as you send the patient home, you wait at least 2 weeks for a scan, whereas if you bring the patient into hospital, they have the scan within 24 hours. So you have patients occupying beds overnight just because they get the scan faster. So do we need to look at more efficient ways of having these virtual wards, or ambulatory care services, or same-day emergency care, whatever you want to call them, where patients go home and then come back for the treatment? If they need IV antibiotics, they go home, they come back for their dose the next day, and then go home again. Some trusts are much better at this than others, but it's a potential solution that could limit the number of patients in hospitals and freeing up beds. And then you've got this continuous flow model, which has been put forward, I think, and trialed in Bristol. It is Bristol, where if you have so say we have an A&E department with 20 beds and 20 trolleys. We don't have beds in emergency departments, and each trolley is occupied by a patient waiting to go to a ward. So there is no space to see the next patient. You can maybe send one of those patients into each ward, even though the ward doesn't have space, and they can wait in the trolley in the ward for a space to come clear. So that's more of like sharing, spreading the risk around the whole hospital, as opposed to the risk being just in the emergency department. So that's a solution that's been trialed in some places and is being talked about in others. National solutions, obviously, the NHS needs more funding. I don't think anyone will argue with, well, some people might argue with that and say we need to increase efficiencies rather than increase funding. But I think, personally, the NHS needs more funding. And most of this funding probably needs to go to social care if we're going to fix our situation, or get any solutions, long-term solutions to our current problem. The future. Okay, where do I see? Do I see this improving in the future? Personally, I cannot see this situation. I can see the situation only getting worse over the next 2, 3, 4, even 5 years. I think people will be waiting longer for ambulances. Ambulances offload time will get longer. People will be spending longer in the emergency department. Emergency departments will be getting more and more crowded. We'll be seeing patients emergency departments will be taking more and more risks, discharging patients who are sick and probably need to come into hospital, but just take more risks. And I think eventually, I cannot see the whole NHS free at the point of care lasting that much longer if we carry on going the way we are. I think we will end up with a two-tiered system where if you can afford it, you will get good care, and if you can't afford it, you will end up waiting 2 days for your ambulance to come and pick you up from the floor. Looking at the policies being put forward by the two leading parties at the moment, I don't think any of them have any solutions to fixing this problem anytime soon. But I would be very interested to hear everyone else's views on that as well. And just to end, we hear a lot about the NHS is at the brink of collapse. I don't think the NHS is at the brink of collapse. I think the NHS has already collapsed. Thank you very much.